Hello and welcome. My name is Joe Ceramelli, and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. Thank you for joining today's Grand Rounds presentation. A couple of points before getting to today's presentation. You can write comments or questions in the chat or the Q&A during the course of the presentation. I can go through those. I'll sort of reserve those, go through those at the end with today's presenter, Dr. Clayton, at the end. I'll mention our Grand Rounds core team. There's several staff members working each week on Grand Rounds, including Samhar Braha on coordination and communications and Mike Walker on technology. I was just mentioning we do record our Grand Rounds and archive them on the department website, which you can check out anytime under the 2022-2023 Grand Rounds series. The series is funded by the Ripley Fund and the Garvey Institute for Brain Health Solutions. We have a new speaker evaluation, which I'll put into the chat close to the end of the presentation. It's just a couple of questions and it's helpful for us in planning Grand Rounds. So please complete that. You can always write overall comments or feedback on the series to me anytime. And now on a little bit about today's presenter. Today's speaker is Dr. Anita Clayton. And Dr. Clayton is chair of the Department of Psychiatry and Neurobehavioral Sciences and professor of obstetrics and gynecology at the University of Virginia. Now, after medical school and psychiatry residency training in Virginia, Dr. Clayton served as staff psychiatrist at the National Naval Medical Center in Bethesda, and then returned to the University of Virginia and has been on faculty since, and as I mentioned, is now chairing the department. Dr. Clayton's research and clinical work have focused on mood disorders associated with reproductive life events, major depressive disorder more broadly, sexual dysfunction associated with illness and with treatments, and sexual disorders. Dr. Clayton is known internationally in these areas, and especially for work in female sexual dysfunction. Dr. Clayton has served as president of International Society for the Study of Women's Sexual Health, on the board of directors of the American Society of Clinical Psychopharmacology, and the World Health Organization Committee on the ICD-11 chapter on conditions related to sexual health. Now, I'll leave it at that for now, and I'll turn it over to Dr. Clayton.
Thank you. I hope you can see my screen now. Oh, nope. Now.
Yes.
Okay, great. Well, I'm excited to talk about this. I've been working on it basically since fluoxetine became available. So it's a pretty long time. Okay, these are my disclosures. I mostly have grants related to the development of either treatments for depression, postpartum depression, or for sexual dysfunction, most of the time female sexual dysfunction, because that's where the need is. And I'm an advisory board to groups working on mostly new paradigms and new treatments for depression. And you can see here that I have some unrestricted stocks, although at this point they're not really worth much. Okay, I want to talk about the biopsychosocial model of sexual response. We talk about this with regard to psychiatric issues, but it's important to try to think about this in the context of sexual response, both what would be considered a normal response and then where someone may be dysfunctional. So at the base is really biology. Right? If something's wrong with the biology, all the other factors could be okay, but that may drive them into problematic areas too. So we're mostly talking about neuroendocrine function, genetics, medical conditions, mostly affecting neurons and endocrine systems, and then medications. On top of that, we've got intrapsychic issues. So it could be performance anxiety, an impaired self-image, depression could be part of it, but also trauma may be an ongoing issue for us that relates to what's going on in our own mind. Interpersonal is the dyadic relationship, the individual with a partner. So looking at the quality of their relationships, both now and in the past, levels and intervals of abstinence. That often happens when someone is not in a relationship, or especially if there's something abrupt that's happened. And life stressors go in this because they can increase the hypothalamic pituitary axis activity. And then sort of the overarching is psychosocial. And we can think about this a lot. Some of it has to do with our own families' take on sexual lives and our upbringing, but also cultural and religious norms are applied, and those may vary with religion or the culture you're living in, and also expectations. And I would say these tend to be more restrictive, and particularly so for women. I want to describe these theoretical models of the sexual response. The linear model was originally described by Masters and Johnson, and it's the white linear arrow here. It doesn't start with desire, that was added later, but it starts with stimulation, because remember, Masters and Johnson were looking at people in their lab. So they said, okay, go in there and have sex, and they monitored them. And so they didn't really necessarily go in there with desire. They started with stimulation, and therefore arousal. There's often a plateau at a high level and then an orgasm. And in men, you can see there's the resolution. In women, they may be multi-orgasmic, and that's what the yellow continuing line is there. And then Helen Singer Kaplan added the idea of spontaneous desire, so that people can have thought, they see somebody attractive and they might have a thought about sex, or they see something in a movie and starts them thinking about sex more specifically. Or it may just seem, I'm going to bed, oh, and here's my partner. And that would lead to desire. In more recent years, Rosemary Basson, who is a family medicine provider with expertise in sexual medicine, developed this circular model, which is really not based on a sort of desire to participate in sex and initiate sex, for example. And so it's not driven by what you're going to experience in sex itself. Sometimes there are biological and psychological factors contributing to level of desire or interest, but in general, she talks about more responsive desire, that once you begin to have sexual stimulation, then you get aroused, and then you will have arousal and what she calls responsive desire. So in response to the stimulation. And often this is driven by things like a desire for emotional intimacy, but it can be driven by negative factors as well. So things like not wanting your partner to cheat, or wanting to satisfy your partner, but you're not feeling that you're getting that much out of it. So this doesn't sound that positive. And in fact, a survey, this is related to the female sexual response. Women were asked about the best fit model. So it was described for them, the Masters and Johnson, the Kaplan, and the Basson model that I've just described to you. And women were asked in 3 different populations about which model was the best fit for them. And so one was a sample of nurses in the community, another was an online survey, and the other was a postal survey in Denmark. It turned out that equal proportions of the women endorsed all 3 models, a little lesser to the Basson model as the fit that was best for them. They had also been administered one of the validated questionnaires in sexual functioning, the Female Sexual Function Index, or FSFI. And in that, they were actually the group who endorsed the Basson model, who had scores on that indicated sexual dysfunction, far more than either of the other 2 groups. And also, it appears that potentially what model is the best fit changes over time. And so there's heterogeneity among women and within a woman. Recent studies have looked at models for men, and they have also asked those same questions. And some men do endorse the Basson model also as representative of their sexual response. But these men are also more likely to have erectile dysfunction than men who endorse the other models. So we often think, well, men don't really have low sexual desire, but they do. And the most representative model is not static. I want to just describe some of the thoughts about neuroendocrine function on sexual functioning, because it'll help us understand about the meds in particular. So in general, desire starts, there's an overlap with subjective excitement, which is cognitive arousal, and then genital arousal, and then subsequently orgasm, hopefully. And what you can see here is that testosterone is a main driver of this system. Estrogen is a derivative of testosterone, but it also has an effect on desire, particularly so in women. And testosterone is much bigger of a driver in men because of higher levels. Progesterone probably has something to do with receptivity to partner's approach. And other hormones that act are oxytocin, which rises and peaks around the time of ovulation in women, so might drive women to be more, want to be closer and have attachment to their partner. And also prolactin has a negative effect if it is at all elevated on excitement. And remember, prolactin is inversely proportional to dopamine. So as prolactin rises, dopamine goes down. As dopamine rises, prolactin is kept below abnormal levels. We also have other factors like neurotransmitters that impact on sexual functioning in the brain, essentially. And serotonin, we know, has a positive effect actually in regulating estrogen, has a negative effect though on testosterone, and then that affects this interconversion. And then also we know that serotonin is able to inhibit dopamine and norepinephrine. Now, dopamine and norepinephrine can impact on serotonin too, but serotonin is a much stronger inhibitor. And then melanocortins, also, which are neuroactive steroids, they act positively on norepinephrine and dopamine, which would then enhance desire and arousal. And in the periphery, again, we've got to have adequate testosterone for nitric oxide to work. This is particularly evident in erectile functioning, but we also have neurotransmitters. So serotonin, as I said, lowers testosterone levels, but it inhibits nitric oxide. And norepinephrine turns on vasocongestion in men and women, so that leads to an erection or to vaginal lubrication, essentially. But it also turns on 5-HT2A, which shuts down vasocongestion. So people who have spontaneous orgasms or who have persistent genital arousal disorder are not shutting this system down. And also serotonin has an effect on sensation. It can either inhibit sensation and reduce it, or it can heighten it and cause hyperalgesia. There's also a reward system in the brain, and you can see it's a little bit complicated here, but I just want to point out that it involves dopaminergic projections, glutaminergic projections, and GABAergic projections. And we know that GABA and glutamate in many parts of the brain are acting in balance with each other. GABA tends to be inhibitory, glutamate tends to be excitatory, and dopamine is generally excitatory and drives pleasure as well. Some of you probably aren't old enough to know about the DSM-4 sexual disorders, but they were based on the phases of the sexual response cycle and also included sexual pain, fairly consistent and parallel for women and men, but women also had dyspareunia and vaginismus, which are pain disorders with penetration, and men had premature ejaculation. And the three criteria required disturbance in a phase of the sexual response cycle or pain, distress related to the sexual problem, and that it was not better accounted for by a medical or psychiatric condition or a substance. So if you had antidepressant associated sexual dysfunction, you were not supposed to use these. But there wasn't really a disorder specifically describing that. And of course, people can have more than one disorder. If you have problems with arousal, then you're probably going to have problems with orgasm. And if you ultimately have problems with orgasm, your desire may diminish as well, because why bother? DSM-5 has sex-specific sexual dysfunctions. That is, men and women are labeled differently. For men, the titles changed a little bit, maybe to be a little bit more PC, but for women, they actually combined low desire and arousal problems into something called female interest and arousal disorder. And that is really lumping those diagnoses together, sort of like saying, because there's a 50% overlap in depression and anxiety disorders, they're the same thing. Obviously, that isn't true. And they combine the two pain disorders into genitopelvic pain penetration disorder, which may, you must then consider those two diagnoses, even though they're not specifically discussed. They added substance-induced sexual dysfunction, which is good. They deleted sexual aversion disorder, which seemed to be more like a phobia. And it required 6 months of symptoms, where all the data in the literature really says only 3 months. And they have to have distress, which was true before. And the subtypes include lifelong versus acquired and generalized, that is in all situations, or situational with a particular partner, or with self-stimulation. The problems were they used a very low level of scientific evidence. It was really based on their expert opinion, and the committee was made up of one psychiatrist and the remainder were psychologists because of the limitation on receiving more than $10,000 in 1 year in total from industry. There were no field trials done, which we know is particularly a problem. No special populations were looked at, and we studied this and found that over half the women currently meeting criteria for a diagnosis of hypoactive sexual desire disorder or female sexual arousal disorder would not have a sexual disorder under this sexual interest and arousal disorder. And so this was really a problem if there was a drug approved for HSDD or for FSAD. And therefore, those might not be available if women had this different diagnosis. The best diagnostic criteria are the more descriptive. This is from the International Society for the Study of Women's Sexual Health. And it's when we think about sexual desire, it's not event related. It is not just something that happens once you start having sex. It can be spontaneous. You can have fantasies, thoughts about sex, and things like that. And you can have any of the following. We've still used the 6-month criteria with lack of motivation for sexual activity. So that's either reduced or absent spontaneous desire, or reduced or absent responsive desire, and loss of desire to initiate or participate in sexual activity. And it causes personal distress. And that's always been a problem for the definition. And this was also well studied and could include frustration, grief, feeling incompetent at sex, a significant loss, anger, sadness, sorrow, dissatisfaction, or worry that it was going to cause a problem in the relationship. Now we can use ICD-11. It's geared toward clinical utility across multicultural and multidisciplinary samples. And it's utilized in this version, a separate chapter on conditions related to sexual health. And it integrates those problems that may be in the mental health realm and also genitourinary systems. And it doesn't matter about the etiology. So if you're on a medicine or you have a medical condition contributing, you can still have the diagnosis. And they reinstated parallel classifications in men and women, except for mostly genital arousal conditions, which are more explicitly described by the sex of the individual. So imaging has shown that antidepressants can be associated with changes in sexual functioning in the brain, or areas of the brain that is contributing to the sexual dysfunction. They took 18 non-depressed heterosexual men. They gave them 20 milligrams of paroxetine, and then there was a washout for 7 days. Then there was a washout, and they got 150 milligrams of bupropion and a washout, and then they got placebo. Although the order of that was random. They viewed erotic and non-erotic stimuli, which is usually what happens when we're doing this kind of testing, in a randomized double-blind fashion using serial fMRIs. And in the placebo-treated portions, the erotic video activated the anterior cingulate cortex, the amygdala, and the hypothalamus. And this was significant change from the non-erotic aspects of the video. And these are the areas that were affected. So you can see, whoops, Paroxetine versus placebo was down in every one of these areas. So particularly anterior cingulate cortex, the amygdala, and other things like related to motivational processing, etc. Bupropion versus placebo seemed to lower reward processing, but probably more fear associated with it, and it increased even over placebo some aspects, activation in certain areas. But then when you compared bupropion to paroxetine, bupropion increased every one of these areas and more that were decreased with paroxetine. So it makes sense when we think about sexual dysfunction seen with various antidepressants. This was another study with 17 healthy male volunteers who took the Massachusetts General Hospital Sexual Function Questionnaire, and they measured baseline resting state functional connectivities on fMRI, and they found that a network comprised of the anterior cingulate cortex, the midbrain, and the lateral occipital cortex predicted SSRI-associated sexual dysfunction with paroxetine. And particularly the ability to achieve orgasm was decreased related to the low midbrain, sublenticular extended amygdala or SLE. And arousal problems were predicted by the SLE anterior insula. When we start to look at sexual dysfunction in the general population, this was a study done of both men and women. I'll show you the men in a minute. That was called the National Health and Social Life Survey. It really was about trying to sort out what was going on with HIV and AIDS coming into the population. And so they interviewed people, 1,749 women ages 18 to 59. So generally when people are thought of as being sexually active, and 43% of those women had a sexual complaint. About a third reported lack of interest. About a quarter said they were unable to achieve orgasm, and about 1 in 5 experienced pain during sex. They did not ask about distress. So it doesn't mean these people would meet criteria for sexual disorders. Later, the PRESIDE study was done looking at a population who had agreed to take all kinds of surveys. And what was found, well, 31,000 out of 50,000 women responded to the survey and completed it with a response rate of 63%, and the mean age was about 49, but the range was 18 to 102. So let's remember that sometimes when people get a bit older, they're still interested in sex. If you just look at the problem, it's pretty consistent with what we saw with the National Health and Social Life Survey, and especially any sexual dysfunction was 43% in that survey. But if you add in distress, you can see that rate drops significantly. So 10% of women had distressing low sexual desire, and about 5% of women had distressing arousal problems or distressing difficulty achieving orgasm. And there was some overlap, obviously. In that, we had also looked at trying to control for depression because it's probably the most common comorbidity. And what we found was that if you had a diagnosis of depression, if you were being treated with an antidepressant medication, or when you filled out the PHQ-9, you met screening criteria for depression, then it basically included about 40% of the people who had had this complaint. So if you reduce the rate by 40% so that you eliminate depression as a cause, then the rate of hypoactive sexual desire disorder is 6%, 3% with arousal and orgasmic dysfunction. So it's useful to recognize there's a bidirectional relationship between depression and sexual dysfunction. So this was a meta-analysis that ended up looking at over 1,000 citations, but including 8 citations, 6 of which included studies on depression, increasing the risk of sexual dysfunction with over 3,200 people, and 6 studies on the risk of sexual dysfunction, increasing the risk for depression, over 11,000 people. And about what we see in clinical trials, for example, for depression, is that it was associated with a 50 to 70% increased risk of developing sexual dysfunction. But more interestingly and more concerning is people who had sexual dysfunction were found to be at markedly increased risk for developing major depression, 130 to 210% increase in that risk. So we need to be thinking about both. This is a unified theory of depression from Dean and colleagues, and I really like to use it in talks about major depression and sexual dysfunction because it's at least more inclusive than just the monoamines. People have thought about, oh, the monoamines are what's causing depression, but recent studies have said it's not the only thing. And I would say to that, duh, it's not the only thing. First of all, we have genetics that are individualized for us. We have environmental stressors or exposures, and those interact to cause epigenetic changes, which contribute to things like reductions in the function of monoamines, reduction in GABA, so a reduction basically in mostly inhibitory effects on more excitatory systems like glutamate, which increases and gets overly excitatory, which causes cells, literally neurons, to die and things. And then there are some hormonal effects like endogenous neuroactive steroids. So things like testosterone, allopregnanolone, and the postpartum depression drug brexanolone is a neuroactive steroid. It's an analog of allopregnanolone. Also, stress increases hypothalamic pituitary adrenal axis hyperactivity, and it can get stuck hyperactive and also then drive some of these systems. Inflammatory mechanisms we often don't think about, but they are related to a lot of medical illnesses, to other psychiatric illnesses, to infections, to things like that. And that also contributes to onset of depression and sexual dysfunction. And then you see reduced neuroplasticity and neural network dysfunction, sort of what I've talked about before. And then that's the pathophysiology, but the clinical phenotype depends on which of these factors are impacted in a given individual. But you do see them meeting criteria for major depressive episode or for sexual dysfunctions. So keep that in mind. The causative factors are overlapping for these two conditions. I just wanted to remind you, if you didn't remember, the HPA axis, basically you see release of things like vasopressin and oxytocin. Oxytocin is definitely related to sexual interest and attachment and things like that. When you act through the adrenals and you see glucocorticoids and things like that, that is going to increase your stress response and that hyperactivity. Thyroid function we know is related to depression, but also diminishes energy and other things that might contribute to sexual dysfunction. As I said, dopamine and prolactin are inversely related. So if prolactin increases, it influences the breast and the gonads and contributes to lactation and may, in fact, diminish sexual functioning during the time of lactation, or if you just have elevated prolactin. And then GnRH stimulates LH and FSH, which we know manages the cycle in women. Men have this as well. And these are diminished, or the signal is diminished so that these are increased in the perimenopause. And so you see reductions in midlife for both men and women to androgen and sperm development and estrogens and ovulation. Okay, I'm back to the National Health and Social Life Survey, the part that applied to men, same age, about 1,250 of them. 14% of those men complained of lack of interest. And often there's a discrepancy between partners. One might have higher desire than the other, but you can see that in a significant percentage, this is the male that's complaining of this. Climaxing too early, 30% of men feel like they're climaxing too early. Mostly, I think, because of thinking about their partner and wanting to please their partner. Premature ejaculation rates, where the individual ejaculates within a minute of penetration, is somewhere between 1% and 3%, so much lower rates. Erectile dysfunction is about 30% overall. It starts in the 40s. Men are using often ED drugs like PDE5 inhibitors for thinking that it will give them a more firm erection, a bigger erection, things like that. Doesn't appear to be true. but maybe that helps reduce their performance anxiety, which is quite high, really. And I wanted to talk a little bit about hypoactive sexual desire disorder in men. This was studied by the two Dr. Seagraves, and they had about, this was in a site that was looking at DSM-3 criteria for sexual dysfunction, and about 30% had HSDD. Their mean age was about 49. They'd had it for nearly 5 years. And it turns out the men with HSDD were significantly older than women who have HSDD, which usually develops during reproductive years, often after having a baby. And of the men with HSDD as their primary sexual dysfunction, about 47%, so nearly half, also had erectile dysfunction. Lots of illnesses can contribute to sexual dysfunction. We know psychiatric illnesses can. Cardiovascular disease tends to be more significant in men. Neurological disorders, urological problems, they tend to be more of a problem in women, especially after menopause. And gynecological problems, especially pelvic floor disorders, can contribute to pain with penetration. Sexually transmitted infections certainly can contribute to pain. Mostly endocrine disorders are a big problem, both for men and women. And then disorders that either make you feel unattractive or alter your sense of self if you've had surgery, or potentially prostate surgery can contribute to erectile dysfunction, but also things like rheumatoid arthritis that limit your ability to get into certain positions. And even having a sleep disturbance can lead to sexual dysfunction. I mentioned this risk is much greater in men than in women. Interestingly, though, higher plasma prolactin levels in the highest quartile was associated with a decreased chance of major cardiovascular events. So there may be some good things about prolactin being elevated. And these are urological problems, incontinence, and these problems are also associated with depression, but it appears that depression starts first, and then you get some of these other urological problems. It's really our responsibility to talk to patients if they don't talk to us. But most adults over 25 said that they would bring up sexual problems with their provider, even if there might not be a treatment, because satisfying sex life is important. You can see pretty close for men and women. Sexual enjoyment adds to the quality of life, and sexual difficulties cause emotional and relationship problems. One study asked if you wanted to talk to your doctor about a sexual problem you were having, how concerned would you be that each of the following might happen during your doctor's visit? And you can see it's basically about 3/4 were very concerned or somewhat concerned that there would be no treatment. The doctor would dismiss their concerns, saying it's just in your head, or being pretty patronizing. And your doctor would be uncomfortable talking about the problem because it was sexual in nature, and they were concerned about making their doctor uncomfortable. So it's our responsibility if they don't bring it up. The ways to do that is make it a part of the routine exam. It's important to the patient. It should be important to you, and patient preferences really matter. You want to identify problems in desire, arousal, orgasm, pain, and satisfaction. And the key is to then identify and address modifiable factors and prescribe specific treatments. So these are some things you can say. I ask about sexual health as part of my regular visits. What I usually do is I ask it as part of the social history. So lifestyle questions: do you use alcohol? Do you use other substances? Do you smoke? Do you exercise? What's your diet's like? Are you sexually active? And then tell me your concerns. And follow those. If they're not sexually active, you might ask why not. And they might say, I don't have a partner. And then I might ask about self-stimulation. And often it's religious prohibitions. What do you assess for? The nature of the problem, which phase is it involving, or which phases? How long have they had it? Is this a change? And was something going on at the time? This dysfunction you're having, is it only with one partner and not with others? Or it goes away when you're on vacation? There may be relationship issues you need to exclude because those should be addressed first. And it's not just a stressor, but you should acknowledge stressors because, like I said, they may be contributing to increased HPA axis activity. And if your partner has sexual dysfunction, frequently then you say it's okay and you don't approach them as frequently or whatever. And that maybe that's what really needs treatment. This is just a screening tool that we like to use for hypoactive sexual desire disorder. The FDA required development of this when flibanserin was being evaluated in development, and it's really simple. There are 4 yes/no questions, and then the patients can tell you, and you can also include some of these factors that might be contributing. This is just about desire or interest, and it's generalized and acquired. But it's very helpful and in terms of determining modifiable factors. Pharmacotherapies increase the risk of sexual dysfunction. We know about antidepressants. It's really SSRIs at about 70%, SNRIs at about 45%, TCAs higher than that. Mood stabilizers, it's less clear cut. Antipsychotics, some do. Benzodiazepines appear to cause sexual dysfunction in women in particular, may help performance anxiety in men. Anti-epileptic drugs that we use also. Antihypertensives, cardiovascular agents, even lipid lowering agents can contribute to sexual dysfunction. And among hormones, oral contraceptives, anti-androgens, and if you give a GnRH agonist, that may also be a problem. The 3 at the bottom are the ones people don't think about. If someone is taking a non-steroidal daily and chronically, if they use H2 blockers regularly and daily, or they use narcotics, any opioids used chronically, daily, long-term, those will contribute to sexual dysfunction. And non-steroidals through prostaglandin, antihistamines through drying effects in particular, and narcotics in multiple ways, including lowering testosterone levels. This is a meta-analysis by Soretti and Cizia, and it basically just gives us an idea about where different drugs compare to placebo. This is placebo, 4th from the left, and agomelatine, nafazidone, and bupropion being the only one available now in the US, have lower rates of sexual dysfunction than even placebo. The highest rates are serotonin reuptake inhibitors and venlafaxine, which is usually dosed at 150 or less, where it is still just basically an SSRI. This is, as I said, between 70 and 80%. This is SNRIs, escitalopram is in here. Imipramine is here. So these are sort of middle of the road, but these tend to be underreported because the side effects of TCAs are far more problematic on a daily basis, like constipation, urinary retention, etc., than people talk, and easier to talk about than sexual dysfunction. A few years ago, we created this graph, essentially, sort of, with rates of sexual dysfunction increasing along the y-axis and the strength of the evidence that is random. These might be case reports on the left, but increasing strength going to the right, which would include randomized controlled trials, specifically looking at sexual dysfunction with validated questionnaires. And you can see first generation antipsychotics and venlafaxine are up here. SSRIs are still pretty close, and some of the atypical antipsychotics and the anticonvulsants. Tricyclics are up here. Quetiapine and olanzapine are a little lower. Here's benzo and lithium and other TCAs. Psychostimulants cause sexual dysfunction. They don't improve it. So there's no point in giving that for that purpose. And then you've got atomoxetine, duloxetine down here. And you've got things we know about: mirtazapine, buspirone, lorazepam. But the evidence is very limited in truth. These are the 4 that you really could be thinking about and feeling confident about, and probably cariprazine too, but that wasn't available at the time we did this. So vilazodone, vortioxetine, and bupropion as the antidepressants, and aripiprazole, and maybe cariprazine as antipsychotics to use when you're avoiding sexual dysfunction. If we think about sexual dysfunction and potentially depression too, but specifically talking about this as a excitation versus inhibition factor, we've got psychosocial and cultural factors that can be positive or can be negative. So if you decide you want to have sex in the bathroom on an airplane, there's probably the risk there might make it more exciting. But in general, having sex in a place that's not necessarily where it's expected would be a turnoff. Physiologic factors that contribute to excitation include our neurotransmitters, like dopamine, norepinephrine, and nitric oxide, hormonal neuromodulators like oxytocin, vasopressin, melanocortins, and the sex steroids of testosterone and estrogen. Those that are going to be inhibitory are neurotransmitters like serotonin, hormone modulators, as I mentioned, opioids, hormones like prolactin, as we've discussed, and neuromodulators like endocannabinoids. So chronic, daily, long-term use of cannabinoids will likely contribute to sexual dysfunction. If you've got SRI-induced sexual dysfunction, you've got a couple of options. Substitute the meds that are less likely to cause this problem: bupropion, mirtazapine, the salicyline transdermal system, vilazodone and desvenlafaxine, duloxetine, and vortioxetine, where there's explicit data in the label now about, but these drugs may be less efficacious for a given individual or tolerated poorly for some reason other than sexual dysfunction. If someone has not done well on previous antidepressants, but they're having sexual dysfunction on their current one that's working, it might be appropriate to add antidotes. Be aware these are all off-label. None have approval for this use, but that might be adding bupropion, buspirone, testosterone, sildenafil to men and women, mirtazapine, DHEA, which is the precursor to testosterone, which converts to estrogen. It's available over the counter, 50 to 100 milligrams a day. And you might also see possible drug interactions, side effects, and an increased cost. Antipsychotic medications that have the lower rates of sexual dysfunction are at least in part due to D2 agonist, partial agonist, antagonist effects, and or 5-HT2 antagonism. So that'd be like aripiprazole, quetiapine, brexpiprazole, ziprasidone, lorazepam, olanzapine, and 5-HT1A agonists, also like aripiprazole, brexpiprazole, cariprazine, and lorazepam. We can see negative effects of antipsychotics related to postpartum dopaminergic blockade, that is elevating prolactin, particularly risperidone. They may have alpha receptor antagonism or priapism. Usually that's a combination of drugs doing that, and maybe cholinergic antagonism affecting arousal. But persistent psychosis, just like persistent depression, also contributes to sexual dysfunction. So decreasing the impact on sexual function with antipsychotics goes from thioridazine, which probably has the highest, down to probably aripiprazole. And I have question marks around lorazepam and clozapine because we don't have a lot of data. Mood stabilizers, it looks like there's less sexual dysfunction with lamotrigine. And benzodiazepines, as I said, it may be that women are more negatively affected. What's the general management plan? As I said, you want to identify and manage modifiable factors. So these could be psychiatric conditions or medical conditions, and you're going to want to effectively treat them in order to decrease disease effects or have them treated by someone else. You also want to eliminate contributing factors like alcohol, other medications, smoking, partner sexual dysfunction, etc. You want to know a patient's preferences, so you can discuss the limitations, including perhaps the sexual partner, alternative positions, psychosocial or relationship issues, sex toys, things like that, how they can incorporate that as a couple. There are psychological interventions that some people might prefer, and there are approved medications for treatment of primary sexual disorders. So I mentioned exclude comorbid conditions, any that cause fatigue. If their sleep is disturbed, reduce caffeine intake, look at their diet. If they don't exercise at all, have a low level of physical activity, that may be associated also with sexual dysfunction and relationship or family issues. Screen for depression if you hadn't already, drug and alcohol use, and you can see them there. Any of those, anything people get dependent on or feel like they need in some way. And then illicit drug use is certainly a problem. What can you do? I'm going to just talk about HSDD as an example. First, you can educate the patient with or without their partner on normal sexual functioning and what might be factors that are contributing or maintaining the sexual dysfunction. We've been doing some research looking at women who are breast cancer survivors, and depending on whatever interventions they have and what meds they're on now, and whether they have sexual dysfunction, when they feel like it would be important to talk about it, when their partners want to talk about it, and how to talk about it, because that's the biggest concern of partners. And then when the doctors who are taking care of them, when do they think they should talk to them about it? And it appears that we should be talking to people before they decide on treatments. Even if they forget about it, they will have heard about it. And you want to individualize the care based on the patient preferences. And you want to consider the risk-benefit ratio, how invasive is it, and the cost. Manage the modifiable factors, and for HSDD, the CNS active agents are approved by flavanserin and bremelanotide in premenopausal women, but they work in postmenopausal women, and off-label bupropion is also good for that purpose. Postmenopausal women, we often use hormones, testosterone, estrogen, and DHEA, and psychotherapy like CBT and mindfulness-based CBT, sex therapy, or couples therapy, which are not readily available, may be of help. I mentioned flavanserin. It's a 5-HT1A postsynaptic agonist and 5-HT2A antagonist. It's dosed at 100 milligrams daily at bedtime. It's effective in about 50% of premenopausal women by 8 weeks, despite what you might have read, because there were people who were not medical who really didn't want people to be diagnosed with HSDD. They didn't believe it existed, and they certainly didn't want them to get meds for it. It's also safe in postmenopausal women, and the common AEs are dizziness, somnolence, and nausea. And you can go to the website. Is Addie is the brand name, and patients can get a treatment right on the site. But you can also prescribe it in pharmacies. Bremelanotide is a cyclic 7-amino acid melanocortin 4 receptor agonist. It's in an auto injector like an EpiPen, and women use it 1.75 milligrams administered sub-Q about 45 minutes before sexual activity. It lasts 24 to 36 hours though. Again, effective in about 50% of women. The most common adverse effect is nausea. So sometimes people might want to take the dose in the evening right before bed, go to sleep, and then participate in sexual activity when that nausea has worn off. There are injection site reactions, not unexpected, and the site is Vyleesi, which is the brand name of bremelanotide. And you use the same doses in postmenopausal women. Off-label treatments, we use testosterone in peri and postmenopausal women. I occasionally use it in younger women, but they have to be massively on contraception so that they don't get pregnant. One of the problems with oral contraceptives is that it can raise sex hormone binding globulin levels, which binds more testosterone and makes free or bioavailable testosterone too low. And the dosing is really, you have to improvise it from available doses for men, essentially. So it's about 1/3 or 1/7, somewhere between there in what men would get. And you do have to watch for androgenic problems like acne, hirsutism, and virilization. If no benefit, I would stop using that after 6 months, but it does take 3 months to probably see a benefit. And bupropion, 300 to 450 of XL is also used in postmenopausal women. See people at regular intervals to monitor progress in treatment. We use the changes in sexual function questionnaire, which I developed to monitor changes across time. And you want to determine if the treatment was efficacious, if they have adverse event, and do you need to change to something else? And decide if they need a specific referral, maybe to their OBGYN or their urologist. So in conclusion, there are multiple biopsychosocial factors that affect sexual functioning across the life cycle. Monoamines, GABAergic agents, and glutamatergic agents, also endogenous neuroactive steroids, HPA axis hyperactivity, and inflammatory mechanisms all impact on this excitatory inhibitory balance and the reward circuitry that really contributes to the overlap of psychiatric conditions and sexual dysfunction. So you really have to do an appropriate assessment. You should initiate questions about sexual function and dysfunction. If the patient doesn't, you want to know about their specific symptoms, identify a diagnosis, and what are their preferences for treatment, because that informs what kinds of things we tell them when we're educating them, what we need to do to modify contributing factors, and consider whether we switch meds, add an antidote, use psychotherapy, or make lifestyle changes. And in that way, our patients hopefully will have been able to be open and honest with us about sexual functioning, and we've been able to relieve their problems associated with either their psychiatric disorder or primary sexual dysfunctions. Thank you.
Okay, thank you, Dr. Clayton. It's an informative description here about sexual functioning disorders, treatment related problems. And we have about 7 or 8 minutes here for a couple of questions, and some have come in. And I think I should just start off going through one. One is more about comparing groups. Why do you think that there's so many people reporting sexual dysfunction without associated distress? I mean, I think on the slide, it was maybe like an 8-to-1 ratio in some of the domains.
So I'd say aging is probably one of the things. Medical conditions too. It's really interesting because sexual function was studied in one study in 29 countries. And what was found was that partner focused relationships and sexual functioning were seen in North America and in Western Europe. And those actually lead to sort of greater expression of complaints versus more Mediterranean and Brazil, where it's more a macho male sort of dominated focus. And so, for example, women may not be as assertive about what they might want. And then mostly Middle Eastern and Asian cultures, it's all about reproduction. And so when it's just about reproduction, you're really not thinking about sexual satisfaction. So I think that's part of it. I think also the availability of effective contraceptive methods has made a huge difference. Because if you're not avoiding sex because you're worried about getting pregnant, then you're going to participate in sex, and it brings the woman really into it for her own pleasure.
Now, a couple of questions about medication treatment specifically. How strong is the evidence, or what is the evidence for medication treatment of antidepressant-induced anorgasmia?
So it's if you want to change to something that isn't acting on the serotonin system, or even if you feel like you need to have that, switching to an SNRI reduces the rates of sexual dysfunction, and that's any sexual dysfunction. So for men, orgasmic dysfunction and arousal dysfunction tends to be higher. Women, their complaints are about desire and orgasm, but they're much more likely to have arousal dysfunction if they're taking birth control pills. It's 8-fold increased. So if you've got a woman with arousal problems and anorgasmia, she's on birth control pills, we usually try to switch the SSRI. But if that doesn't change things, we measure SHBG and testosterone levels. We look and see if she has very high SHBG. Then we might have her birth control changed from an oral contraceptive to something else. And we've often found that that actually is what makes the difference, not changing from the SSRI. So it's very treatable if you switch. It can be treatable if you add an antidote too. And so that may be a bit of trial and error.
Antidotes are the next set of questions here. So I think it's good you mentioned that. A specific question about bupropion, maybe perhaps the most commonly used, or one of the most commonly. Do you advise people sort of push the dose? Is there an upper limit for what might be effective? Would you expect a response early on?
We studied it, and we studied between 300 and 400 of SR milligrams a day, and it was a very short study, like 4 weeks, and we saw people back pretty regularly, and we saw improvements relatively rapidly. And if they had improvements, then we attempted later to taper their SSRI, for example. I definitely push to high doses. The data says 150 of bupropion, no matter what formulation it is, doesn't work. There are a couple of randomized controlled, placebo-controlled studies, doesn't show that. But 300 milligrams can work, and 450 may as well. And we know people, when we're just treating with bupropion for depression, not everybody responds to 300 milligrams of the XL. So use it, push it. And the idea that XL is going to make people anxious is just not true. And especially if they're on something else that would treat their anxiety.
And then a more general question about medications for sexual dysfunction. Is there evidence of differential effects of any medications for different sexual dysfunction?
Well, so for example, sildenafil in women and men is effective only for genital arousal. In fact, it doesn't even improve orgasmic function, which is really kind of interesting, because if your stimulation and your arousal is improved, it should potentially contribute to orgasm, right? Bupropion definitely also not only contributes to desire, but it contributes to arousal and orgasm. And same with flibanserin and bremelanotide, the products I mentioned that are approved for premenopausal HSDD. They definitely also improve arousal and orgasmic function, which is quite reinforcing in the people who do respond. So I think it does vary. I often, there's one study of adding mirtazapine, and we sometimes do that, but the plan would be to switch them probably to that because it has lower rates when used as monotherapy, essentially. So, and I usually don't, I mean, I'm usually giving them 30 to 45 milligrams, and we really don't see a lot of appetite increase or severe sleep, sleepiness.
Maybe a very direct question for the seconds we have left here, but is flibanserin, I mean, given its mechanism as a 5-HT1 agonist, antagonist 5-HT2, is it evaluated in other disorders, treatment of other clinical problems? Is that underway? Are you aware of that?
No, it was originally evaluated as an antidepressant, and they administered the Arizona Sexual Experiences Scale during the randomized controlled phase 2 trials. And they found that in women in particular, they had improved sexual functioning on flibanserin. So then when it didn't separate in terms of antidepressant efficacy from placebo, then it was looked at for hypoactive sexual desire disorder. And they have the data about female sexual arousal disorder and orgasmic dysfunction. But that the group, the section at the FDA that deals with this is somewhat biased against women's sexuality. I mean, there's a lot of concerns in culture, right? That women shouldn't be having sex, like men do, as often or with multiple partners or whatever you might think about. That is fading, I would say. But I think that bias was clearly seen in the FDA, and we had to advocate a lot to have it considered differently. At the time of the approval of flibanserin, that was the first treatment approved for sexual dysfunction in women, and especially for the most common disorder. And there were 27 drugs approved for men for sexual dysfunction. So
a notable difference.
A notable difference.
Notable difference. Here we are, just a minute past 1 o'clock here. And there were other interesting points that came up. I think there's questions related to cannabis use that you had mentioned about contributing, other questions, but we are at the time. And Dr. Clayton, I do want to thank you again for joining us for Grand Rounds, for presenting today on a really comprehensive topic. And thank you. And we could leave it at that. So
Thank you for having me.
take care.
Bye.